This is Group 4's EPP project, where we asked, is it better to instill normal saline prior to suctioning of an endotracheal tube or not? In a spirit of inquiry, we will present our journey to search for best practice, evaluate the evidence, propose a practice change, and how to implement it at our site. The background for this project is that ventilator-associated pneumonias, or VAPs, are increasing nationally. The risk of not improving VAP rates are increased deaths for patients, increased patient and hospital costs, and poor patient outcomes with increased length of stay. The Quality Safety Committee at City Hospital recently reported increased rates of VAP in the respiratory ICU. The nursing staff initiated a project to look at possible practice changes surrounding mechanically ventilated patient management through an evidence-based practice process. The site is a 12-bed adult intensive care unit at City Hospital, which is a level 1 urban medical center with 300 beds. Most patients are mechanically ventilated with an RN staff of 1 to 2 to 1 and a dedicated respiratory therapy team. Through an EPP project, a review of present ICU practices was done, where the practice of instilling normal saline prior to endotracheal suctioning was identified for best practice evaluation. Our challenge was to develop a PICO question that was the right question. The target population was intubated adult ICU patients, asking how does suctioning ET tubes with normal saline compared to not using normal saline prior to suctioning affect overall patient outcomes concerning VAP rates. The VAP rates would be compared from May 2021 to June 2022 with previous year rates. A summary of the best evidence included 10 keeper articles that were reviewed and appraised. The research supported not using normal saline prior to suctioning. Normal saline use was reported to decrease patient oxygen saturation, increase patient lengths of stay, and rates of ventilator-associated events. The American Association of Respiratory Care in 2010 already recommended against the instillation of normal saline prior to suctioning. The articles also examined the prevalence of varying practices among staff around the world that failed to incorporate current recommendations and remained as barriers to practice changes. In order to establish attainable objectives for our project, our group developed 5 SMART goals. All goals are specific to our population and include decreasing the rate of ventilator-associated pneumonia by 50%, decreasing the number of staff observed utilizing normal saline for suctioning, have patient oxygen levels return to baseline within 10 minutes or less of suctioning, decrease average intubation periods, and decrease hospital spending related to ventilator-associated events. A Gantt chart was developed in order to measure our group project progression related to our project objectives and the EPP process. Steps 0 to 3, seen here, include the preliminary processes of cultivating a spirit of inquiry, identifying a problem, performing a SWOT analysis related to this problem, and developing a PICO question. Additionally, these steps require a thorough research process to identify and appraise the best evidence to support process change. Step 4 involves the process of integrating evidence with clinical expertise and patient preferences and values. Additionally, these steps include establishing SMART goals, determining evaluation tools, development and proposal of a budget and sustainability plan, and attaining approvals for project implementation. Step 5 includes identifying and meeting with key stakeholders, evaluating outcomes and measuring the impact of this intervention on patients, the healthcare system itself, VAP rates, and hospital ICU length of stay. And lastly, the actual launch of the EPP implementation project. The final step, Step 6, measured in our Gantt chart, is intended to analyze the project data using our specified measurement tools in order to disseminate our outcome findings and determine whether the outcomes support our proposed EPP change. A sustainability plan was developed to identify strategies to ensure long-term success and integration of our practice change. This plan included identification of key stakeholders in order to facilitate this process, as well as inclusion of the ICU clinical nurse leader to educate ICU nurses and respiratory therapists through hour-long classes and pamphlets provided on the unit. The Chief Nursing Officer is also included in this plan and integral in ensuring executive leadership support and financial backing for this practice change. Reiterating the improvements and expenses related to care of ventilated patients, including emphasis on the return on investments, will also ensure long-term success. Through completing this project, we have learned how to navigate research databases and effectively identify evidence-based studies to utilize toward change in best practice standards. We have also learned about the different levels of evidence and how to discern between relevant and statistically significant findings through research appraisal. Additionally, we have had the chance to practice coordinating with our peers in the process of EVP change. In the future, we will have a questioning attitude when approaching nursing practices, and we will work with our leadership to promote the need for change. We will utilize this knowledge in our future practice to implement evidence-based changes that will ultimately help us to provide the best care to our patients.